It is an honor to introduce our very first speaker, Dr. Fahad Qiyam. Dr. Fahad is an accomplished oral and maxillofacial surgeon currently serving as an assistant professor at Sardar Begum Dental College, Gandhara University, Peshawar. He holds a Bachelor of Dental Surgery (BDS), has completed his fellowship in oral and maxillofacial surgery (FCPS), and is also a member of the Royal College of Surgeons of Edinburgh. We are truly honored to have him as our first speaker today and to set the tone for the sessions ahead with his valuable insights and experience. Screening. Today, he will be speaking on a very important topic, which is screening and early detection of oral cancer. This is a critical area in clinical practice, as early identification of suspicious lesions can significantly improve patient outcomes and reduce the burden of advanced disease. As dental professionals, we are often the first point of contact, making our role in screening and timely referral extremely vital. Without further delay, I would like to invite Dr. Fahad to begin his session. Over to you, sir.
Thank you very much for that very nice introduction. I think if you'll have to make me the host so I can share my screen, or can I share my screen?
Anyway. No, sir, you can share your screen already.
All right, wonderful. Thank you.
Welcome.
All right, so Assalamu alaikum everybody, and thank you all for registering for this webinar, and I hope that inshallah by yesterday and by today's lecture you'll be much more informed and you'll have a clearer idea of how to proceed with cases in which you suspect that there is maybe a malignancy in play, and hopefully we all can play a better role in the management of such conditions. So the topic that I'll be talking about today is screening and early detection of oral cancer in daily practice. So before I begin, let's just briefly share the contents. Today we'll be talking about epidemiology, roughly about epidemiology about oral cancer. Then whenever we are talking about early diagnosis, we should always know about what are the reasons that diagnosis is being delayed in the first place. What are the common risk factors, early signs that we should be wary of, how to screen for oral cancer, and lastly, what can we do in our capacity as a general dental practitioner. And since I believe the bulk of our audience is mostly general dental practitioners or young dentists, so I think I've tailored my last portion of this talk basically at you guys, that what you can do at your level. So I'm sure there'll be a lot of discussion on the prevalence of oral cancer, about the epidemiology of oral cancer, but it's still nonetheless very important that we discuss it because I feel that probably as a maxillofacial surgeon, we have a lot of interaction with such patients, and the state that we see our patients in, it is regrettably so deplorable that I feel that we are not doing anything at all for them other than just taking them out and just waiting for their death to happen. So this is a graph from the epidemiological assessment of oral cancer burden in Pakistan. I've given the reference below. It's an open access article. So in Pakistan, if you look at figure A, total number of new cases, if there are 100 cases in Pakistan, so most probably 11 of them are oral cancer cases. Like total cancer, all sides of the body, of them 11% is belongs to oral cancer. And while you may think that that's not a really big figure, but if you look at figure B and look at how many related deaths do we see, so the percentages are roughly the same. It means that almost all the cases that are being diagnosed do eventually end up in death instead of cure, or I would say a good 5-year or 10-year survival. So if you break this down by gender, so unsurprisingly, it is the leading cause of death, cancer-based death in Pakistani males, and the second most common cause of death in females, cancer-related death, second only to breast cancer. Of the 43 countries worldwide which have a high risk of oral cancer or high prevalence of oral cancer, Pakistan ranks 7th out of 43. So this is not a good top 10 position that we are having. And it just goes to show you that there is an extensive burden over here which needs to be tackled. So, like I said, whenever we talk about oral cancer, it's a very generic term. It includes a lot of cancers. If you've gone through the WHO classification of oral cancer or oral lesions, it came out in 2022, so you can go through that. It's freely available online. But the thing which interests me most is that of all the cancers that are mentioned in there, squamous cell carcinoma is something you must have heard of. And based on the following two studies, and one of them was actually my dissertation for my FCPS part two, in which I wanted to see what are the most common histological types of oral and maxillofacial malignancy, and another study which was conducted by the PARC in Karachi. So 90% of the oral cancer cases that you will see, over 90%, they are all oral squamous cell carcinoma. So I think, in my humble opinion, if it is one cancer that we need to be able to recognize and treat very well, should be squamous cell carcinoma, given the overwhelmingly high percentage that it brings to you, it will come to you in your practice. So I would just like to do a little poll, if that's okay. And I just actually, and this will carry on the context of the previous slide. And in that, I want to know that how many of you have actually seen a case of oral squamous cell carcinoma? So anybody who has can just let me know in the chat box, or you can just unmute yourself briefly and let me know. So because we have about 22 people, well, 21 excluding me. So how many of you have seen a case of oral squamous cell carcinoma? So we have one person, Dr. Mashud, he says, I've seen many, many cases. Well, that's very nice. Dr. Mohammed Rabe says, I haven't seen. Dr. Eliza says, I have seen. So, Filal, 2 out of 3. Yes, participants, please wake up. Do let me know what your answers are. So, it's important because it will probably bring me, it will give a lot of weightage to my upcoming point. And so we have, okay, 4 people. So 50% have seen a case of squamous cell carcinoma. Okay, now still 3-3. Okay, 4-3. 4 is for not seeing, 3 who have seen. Yes, other participants haven't. All right. So basically, what I'm briefly getting from all of this is that maybe the nays have it that not a lot, that probably 50-60% of you have not seen the case of oral squamous cell carcinoma. So if something is so prevalent, that oral squamous cell carcinoma, and 50-60% of us are saying we haven't even seen a case, so how do you expect to diagnose it? How do you expect to treat it? How do you expect to refer it out? That yeah, this is squamous cell carcinoma and needs to be treated. So there are a lot of problems. It means that probably our clinical exposure is letting us down in this regard. So what I've done is that I've collected a few pictures of oral squamous cell carcinoma that I came across in my trainings. Some of my juniors were very kind enough to share pictures of these. So basically, before I come to the picture of squamous cell carcinoma, how it looks like, so you need to know what to look for, basically. So this is a figure which I've taken from an article which I'll discuss later on. But typically, you have an ulcer, all right? You have a central area of an ulcer. You have raised edges at the periphery or at its border. And since it's cancer, it will come with its own blood supply, so it will have its own blood vessels, so that area, surrounding area will be quite reddish. And since it's trying to invade the tissue, so there will be some fixation there as well. So these are 3-4 very prominent signs of squamous cell carcinoma, and I'll focus a lot on, and I'll probably be emphasizing the role of fixation a lot in my stories ahead. So just keep these 3-4 things in mind. So here we have case number 1. So this is, as you can see, squamous cell carcinoma on the lateral border of the tongue. So you may not be able to appreciate ulceration as such in it, but you can see that there is extensive erythema, which is probably due to the angiogenesis. You are seeing reddish areas and whitish areas. All right. So again, feature of malignancy, erythroplasia, leukoplakia, keratin pearl formation. All right. And when you palpate it, especially at the borders, this region over here, so this will be very firm to touch as compared to the rest of the tongue. All right. So this is one way it's in which it can look like. It can also present like this. So in this, you can see a huge ulcerated region and the alveolus, anterior alveolus of the mandible. So this entire area, this is the necrotic part. This is the area of the central necrosis. So this is the periphery, all right? So the periphery over here, you can see probably there's not a lot of erythroplasia. You can appreciate here a lot more white patches as compared to the reddish one. But again, the borders are very tough, and this was actually the area where we took the biopsy from. So you've seen that in a wedge shape fashion over here. So if you compare these two very different images, now I'm going to show you a third one, which is even more different. So look at this one over here. Small lesion, central area is a bit red. You have maybe some wart type leukoplakic growth over here. Peripheral area is again is seemingly leukoplakic, a little bit white. But again, if you palpate it, it would be quite hard due to fixation and induration. And you can even see a silk suture over here because this is where we've taken the biopsy from. And this turned out to be, I believe, moderately differentiated squamous cell carcinoma. Now, the last picture I'll show you, this will be in complete contrast to all the other pictures that I've shown you. Look at this. Now, do you think there is an ulcer over here? There is anything over here? It looks actually like a cauliflower. So I think to call it a cauliflower would probably be an insult to cauliflower. So, but here you have a proper exophytic growth. Remember, squamous cell carcinoma usually shows two patterns. It can be a hybrid, can show both of them at the same time, but you may have heard of the term endophytic or exophytic. So by exophytic means it is coming out, it is showing a growth from the mucosal surface out in an outward direction. And in endophytic, it means it is invading the tissue, it is going inside the tissue and causing invasion and creating growth, growing in that direction over there. So this is a very exophytic growth, and we came across this, and we could not understand where to take a biopsy from because it's such a huge lesion. So you have a very varied type of appearance, and again, if you see it, you'll be able to recognize it. If you don't see it, you can't again. Then probably it's not really your fault to begin with. So it's very important that you know what it can potentially look like. So, since the first part of my talk is about early diagnosis, so before we go into that, we should know what are the factors that cause delays in diagnosis. So, when I was in training, one of my seniors, who is, mashallah, now herself a supervisor in Lady Reading Hospital, her thesis topic, I found it extremely interesting, and I thought my topic was very bland compared to her. And she was doing research on causes of delay in oral cancer diagnosis. And when I heard that topic for the first time, I thought, why would oral cancer get delayed? Why? I mean, it should be diagnosed as early as possible. But when I read her thesis, it opened up so many eyes of mine. And if you come across it, the author is Dr. Sana Wazir. Do go through it. It was one of the earliest works that I came across on this topic. This was a study done in our center, Khyber College of Dentistry, Peshawar. So now we have done quite a lot more work. This is the article that I'm be discussing now. This is quite more recent. I think this is of 2021 or 2025. So, what are the delays in diagnosis? Why aren't patients getting diagnosed on time? So, the first cause is patient-related delays, and these are also called as appraisal delay. What is appraisal delay? Appraisal delay is the time from when the patient had a symptom and the time they had the symptom till the time they actually went to a doctor to see, to have it checked out. So I'm sure a lot of us can relate to this. Whenever we get some aches and pains anywhere, or we're feeling feverish or anything, we wait for a couple of days. We think, or probably be the seasonal flu, or maybe this or that, or maybe I pulled a muscle doing something, and it'll get better after a week or two. If it doesn't, then I'll go see a doctor. So this is called appraisal delay. So this is prevalent in over 65% of cases of all patients who eventually end up diagnosed with squamous cell carcinoma, most of the patients do not consider their symptoms serious enough to get diagnosed on time. So that is one aspect of it. What is the second aspect? Second aspect is diagnostic delays. Diagnostic delays, uh, in that portion, we actually come to the fore, and here where the fault in us comes to light. So diagnostic delay is the time from when the patient first had the symptoms till the patient got a confirmed diagnosis of squamous cell carcinoma. So this can potentially include time of the appraisal delay, but here an additional factor here is that when the patient came to us, when did we diagnose it? All right. Did we take 2 weeks? Did we take 1 month? Did we take 100, 200 days? How many times, how much time did we take? So in 51% of cases, we had delays because of us doctors, because we did not have a high index of suspicion for what we were treating or what we were seeing. And we either thought it was something else, it was an infection or anything, and we just medicated the patient, or we took a biopsy, did not take it from the right place, and it just ended up being non-specific inflammation, which surgeons over here who are part of this webinar and especially those dentists who routinely treat such cases, they might have come across this biopsy report very common, chronic non-specific squamous inflammation. So this is something what we get when you don't take biopsies properly. So what did they figure? What was the result of this paper? So delays in diagnosis arise from inadequate patient awareness. Rural residents, all our patients who live in their villages, traditionally we see a lot of delay from them. And traditionally you will also see them using a lot of traditional and complementary medicine, homeopathic medicine, herbal medicine, dumb, spiritual medicine, anything. They feel that it will save them from a doctor, and actually ends up just creating more delays. And there are obviously, and lastly, health system challenges. So improving healthcare access and public awareness are crucial. So this was insight from Pakistan, study done in January of this year. Again, it's open access, so you can go through it if you're more interested in finding out what causes delays in diagnosis. And it's a very interesting research topic if you are so inclined. So, what are the risk factors? So, I'm sure you've gone through risk factors as a part of your undergraduate curriculum. A lot of speakers today will probably be talking about it as well. But I actually wanted to give a local context to it. I wanted to research papers that which had identified risk factors in our population instead of just giving you the bookish answer to it. So, smokeless tobacco, cigarette smoking, genetic predisposition, and HPV, human papilloma virus, are considered significant risk factors for oral cancer in Pakistan. So as you can see, this is a systematic literature review done 2 years ago, and it was published. The link is all obviously there. I think it's open access as well, so you can go through it if you are so inclined. So it is telling us that of the maybe 15, 20 risk factors that we used to wrote for our oral pathology viva when we were in our third year, because the internal or external examiner is going to ask us this. So of these are the 3, 4 areas which we really need to work on. And if you, out of probably these four, three are such that they should be enabled to good public health campaigning. So it means that it is significantly preventable. Now, one thing that they did not address was the prevalence of OPMDs. So OPMDs are oral potentially malignant disorders, and this is a term I hope you guys are familiar with, because if you're not, then it's the problem. It's because of your teachers. It's not because of you, because you have studied precancerous lesions, precancerous conditions, or pre-malignant lesions and pre-malignant conditions. And what WHO has done in 2006 was just combine these two and give them a new name. So they are now called as PMDs, potential malignant disorders, or oral potential malignant disorders. So a lot of the times, a cancerous patient will come to you in the state of having a potentially malignant disorder in their mouth, and you need to be able to recognize it and then treat it appropriately and follow it up appropriately as well. So I'm sure again you studied this in oral medicine or oral pathology of third year. But again, we need to give it a bit of a local context. We need to know what are more prevalent here in Pakistan. So this was a study done quite recently. I'm sorry, I've forgotten to add the year of it. But this was done, I believe, 4 or 5 years ago. So they studied what potentially malignant disorders do you have more commonly in Pakistan. And of the 10, 15 that our teachers used to teach us, the most common ones are actually oral submucous fibrosis, oral lichen planus, leukoplakia, and in the end, you can have maybe actinic keratosis and erythroplakia. So, in addition to recognizing what are the most common what does oral cancer look like, you also need to know what oral pre-cancer looks like. So I'm sure most of you have seen patients of lichen planus, if not in your undergraduate years, then I'm sure in your clinics. So typical Wickham's fry lines, white lines are present, sometimes with erosive areas over here, which you can see. And these are areas which you need to be more concerned about. They have a higher potential for transforming into oral cancer. Overall, I believe the malignant transformation potential for lichen planus is about 1% or 2%, not more than that. But I actually have seen one case which has actually transformed into squamous cell carcinoma. And secondly, which is most common over here, is your oral submucous fibrosis. So typically, the mucosa will appear like this. When you see the patient, there is usually an absence of a lesion unless it has already transformed into oral cancer. But here, your palpation is very important. So I would recommend you always palpate all the lesions that you come across. Don't just see them with a mirror. Palpate the lesions. And here, the point of induration fixation will again become very relevant. So that the one case of lichen planus that I saw which transformed into oral cancer was one of the very few cases that I actually palpated. And there I felt something that maybe this lesion is fixed or indurated somewhere. And I referred that patient to our department for biopsy. And when I saw that patient, maybe about a year later, she had undergone a partial maxillectomy for her squamous cell carcinoma. So, in a way, I was glad I diagnosed it, but I was then quite sad that the treatment was so prolonged that she had to have a maxillectomy to get rid of the condition. So, again, some mucus fibrosis where you will not come across a lesion per se, but you need to palpate the buccal mucosa and you will feel the bands with your hands. So your hands are very important tools for the diagnosis in such cases. So whenever you're coming across them, and that is the second part of my talk today, that is how to screen such patients. So typically, I will always recommend to my students, and I'll tell all the participants here, you need to start with your histories. You cannot escape a history no matter what you do. You want to be a good doctor, a good dentist, you need to be able to take a good history. So, taking a history of these socially acceptable drugs of pan, gutka, chalias, cigarettes, and all these newer things like your velos and whatever everything is the smokeless tobacco pouches that you have, and nicotine pouches that you have. So again, very important. Family history is also very relevant. Like I said, in the last 5, 10 years, I would say we came across quite a few patients who were less than 40 and they were reporting to us with we diagnosed them as squamous cell carcinoma. And here, the family history was very important because there was an absence of other risk factors in such patients. So, clinical examination, what are you supposed to do? You are supposed to examine the patient as per the WHO Institute of International Association for Research on Cancer Protocol. I'll be showing you a video on that, so please do stay tuned for that. And I'll share this presentation as well, so you can, if you miss anything, you can go through it at your own time and pace. And here I'm again stressing on the fact that you need to palpate all of your oral potentially malignant disorders. Palpation is very important. And lastly, you have a couple of adjuncts which you can choose depending again on your finances and on your expertise. So early signs, Pride has done a very wonderful job of showing a lot of pictures regarding the early signs of oral cancer. The big four signs, I wholeheartedly agree with them. Those are most definitely the signs that you definitely do need to watch out for. I came across a much more extensive list of signs, which was published in this article in Science Direct. Again, open access here, so you can go through it whenever you want. So they came across these, they made an acronym out of it, no red flag. So no is nerve palsy, R, E, I don't know what D stands for to be very honest. And flag is facial pain, lesion, alteration and cessation, gustatory disturbance, sore and ulcer. So in addition to no red flags, you have some other symptoms particular to maxillary carcinoma. Non-healing socket can also be a sign of oral cancer. And if some of you are inclined towards, especially surgeons, PMOs, who have done some work in ENT, so they may be able to diagnose a nasal mass. So they can have some, they can take a good history and maybe diagnose cancer there as well. So in my personal experience, an enlargement, a lump, a swelling, having a lesion specifically for more than 2 to 3 weeks, that always makes me have my, like Spider-Man has a spider tingle, so this raises my malignancy tingle. So you have an enlargement or you have a lesion which is lasting for more than 3 weeks, I get suspicious and I probe that patient much more in detail. A lot of our patients actually give us a history, and maybe you guys have come across this as well, that tooth mobility. We had a very mobile tooth, we extracted it, and then we developed oral cancer because of it. So you'll hear this story a lot from patients. We've seen it a lot in KP, and maybe you guys have come across it as well. A few cases we actually diagnosed based on this, having a non-healing socket. So all of these factors, all of these no red flags should raise your suspicion. Keep in mind, none of them are specific per se, but they warrant that you probe the patient more, you examine him or her more, and you at least follow up or do a little more investigation than which you would normally do. So the difference could be life and death for the patient. So sore and ulcer as well. So these are the 5 factors which I feel should definitely raise your suspicion. So I was talking about that WHO IARC oral screening. So I typically teach my students this. I don't tell them this is an oral cancer screening, but this is how I teach them intraoral examination for their final year. So it's a very good tool for screening a patient, and does hardly takes 1 to 2 minutes. So I'll just play this small video, and the link is again over there. You can examine it. So it doesn't matter if you can hear it or not, but you can just look at where what is being said and what areas are being.
Excuse me, sir. Sir, the video is playing, but we cannot hear the audio.
So as you can see, it's a very straightforward but systematic way of screening patients for oral cancer. You are basically doing a complete examination of the soft tissues of the oral cavity and of the oropharynx. and you're not just focusing simply on what the complaint of the patient is. So, and as you can see, it hardly took 2 minutes. So it's not something which is very tiring or cumbersome. So this is a second step that you can do. Thirdly, if you have a good index of suspicion, or if you're so inclined to invest a little in your clinic and have a little bit of these new tools. So you might have heard of VL Scope. This is a light-based oral cancer screening device, which was launched in Pakistan about 2 years back. A bit expensive. Its price is rumored to be in the range of 5 to 9 lakhs. But again, if you look at the difference in the pictures and what it is telling you, so if, especially if you are practicing in a high risk area where you come across a lot of oral cancer patients, or you're dealing with oral cancer patients yourself, I think this could be potentially be a good tool that you have in your practices. So there's a company called SBK International. I believe they're based in Islamabad. They brought it here, launched it 2 years ago at HPS Dental College, if I'm not wrong. So if you're interested, look them up, and maybe this is one thing you can have, which requires very little from your end, except a deep pocket. So it highlights areas which are potentially malignant, and then you can obviously take a biopsy to confirm whether that is true or not. So more recently, there is a lot of work currently going on in the use of mobile phone like technology and a software-based system to diagnose oral cancer. So this is currently not available as an app in your phone. I tried to check for it, but they haven't launched it yet. But potentially, this could be something that happens because I think this was an article of last year. So maybe in a year or two, you if you don't feel like investing in a very expensive light-based source, so maybe this is something that can be more up your alley. So they're calling it MDOC. The name is here MDOC. So this is something that has the potential to change things. However, I think there's always good to have a Pakistani way of doing things, if you will, if you can, what we call, jugaad, if you want. So typically, if you studied pre-malignancy, you would know that toluidine blue is a dye that was used for detection of oral cancer. So there have been a couple of studies recently, 2024-25, in which they used a much cheaper alternative called methylene blue, and this was actually first stated in an article way back in 2006 in the British Journal of Oral and Maxillofacial Surgery, and this showed quite decent performance as compared to toluidine blue. So this is something which we can use. So if you go across the articles, this 2024 and 25 one, I believe it was done in Foundation University College of Dentistry. So they've given a very detailed methodology of how they've done the study, and I think it's quite easy to do. You can do it if you want in your clinics, and it won't cost or break your bank a lot. So, lastly, what can we do? What else should be the take-home message? And I believe that whichever talk we have, we should be able to give you some, instead of depressing you with statistics and data, we should tell you what can you do, what role can you play. So, first of all, like I said, taking a detailed history from all your patients regarding the common risk factors. We unfortunately have a very bad habit of not taking a detailed history. We just focus on the tooth or whatever pain complaint patient has, and we don't bother going into their personal history, especially regarding these smokeless tobacco and their use. So this needs to be part and parcel of our history taking. It will maybe take a minute more. So, like I said, could be the difference between life and death for a patient. In addition to this, what else should we do? Like I said, you should examine all patients as per WHO IARC protocol. Make it this a habit. If you do it for every patient, you won't have to remember how to screen a specific patient. Just examine every patient as per this protocol, even if they have no risk factors or nothing. Remember, having a risk factor is not mandatory. Sometimes you can have a genetic predisposition, and you may miss a patient because of this. The third thing that we don't do is following up on our cases. And I am I won't sit here sitting on a pedestal and say I follow up on all my cases. I am part of the problem as much as I'm saying this, but I do try to at least give these patients regular appointments so we can see them, and this is something we need to do. So even if you, this should not be a standard of care that आपको जब मसला बन जाए या जब तकलीफ ज्यादा हो तो तब आप हमारे पास आ जाएं, हम आपको देख लेंगे. So you're putting the whole burden of early diagnosis on the patient, and you're sort of removing it from yourself. So that is not the way. Just as you see all your other regular follow-up patients of your root canals or your any other thing. So make this a habit, especially for your high-risk lesions. A 2 to 3 month monthly follow-up is recommended, and for low-risk lesions like simple leukoplakia, you can maybe see them, evaluate them after every 6 months. So make this a habit, give them an appointment, and follow up on such cases. All it takes is just taking their phone numbers. At least you can say that you called and you guys did not come, but I kept calling you on your appointment days that you have not come up for your follow up. So if you and you cannot even say that जी डायरी में नहीं लिखा था भूल गया था असिस्टेंट से भूल गया. आजकल you have a lot of practice management software which are available, and they just cost maybe 5-6 thousand a month. So they can do this follow up thing for you via WhatsApp and whatnot. So please do a little bit of investment in yourself and just take a bit of time, take their phone numbers, enter these patients, give them appointments, see them regularly. So you can diagnose it as early as possible. So this was about yourself. Now, what about us as public health campaign? Well, I'm not a public health expert myself. I don't sit with them a lot, so I don't know what areas are they targeting for public health campaign. But high consumption areas of tobacco, smokeless tobacco, especially our rural areas, and especially those areas where we are seeing a lot of high risk use or maybe even genetics as a potential cause, those areas should be targets for public health campaigns and research. One thing for us teachers is that, and this is something I do, so that's why I feel I can say this, that we should be teaching biopsy taking for oral squamous cell carcinoma. And this is not something we should leave just for the specialist or just for the maxillofacial surgeon. It is one of the shortest procedures you'll do. It will take less time than extracting a tooth, but if you can do it properly. So it's a very simple thing. I teach biopsy taking as a skill lab in my college, and I hope that other teachers who, if anybody is attending or anybody who watches this webinar, we should try to delegate biopsy taking for squamous cell carcinoma to our dentists because they are much more prevalent across Pakistan in rural areas as compared to us surgeons, where most of us are just focused or settled in the urban areas. So that can potentially help diagnosing such cases very early. Lastly, if your teachers are not teaching you, well, that does not mean you cannot learn it somewhere else. So please, I would advise you guys to take courses on minor road surgery wherever you can find them. I know they're not as common as your C endo and C ortho and C implant courses, but wherever you find them, especially if they're teaching you biopsy, please do go ahead and take the courses. So usually I do end with a funny slide, but this topic did not merit a funny slide. And actually, this was one of the questions that was asked me in the chat box. I hope this partially answers it. This was a study conducted in 1989, which was studying the 5 year survival rate of oral squamous cell carcinoma cases by stage, irrespective of site. I'm sure you heard that there are oral cavity, there are some high risk sites, there are some low risk sites. So overall, based on stage 1, 2, 3, 4, so the overall 5 year survival for squamous cell carcinoma is 64.5%. If you come in stage 1, your 5 year survival is almost 93%. If you go to stage 2, almost 85%, stage 3, 50%, and stage 4, 16%. So this was a study actually done in 1989. And truth be told, if you come across latest literature on this topic, you will not find a lot of changes in these percentages. So currently, there's a lot of work on immunotherapy going on. I do hope, I pray that it translates into meaningful changes in the 5 year survival rate of such patients. However, currently, as things stand, in percentages, में शायद 19-20 का ही फर्क आया होगा, and not a lot. So that brings us to actually the crux of my topic and over the take-home message of my topic, if you will, and that is that early diagnosis and screening is not curative, but our lack of action is a surefire death sentence for our patients. So if we can screen them earlier, if we diagnose them earlier, we can catch them in stages 1 and 2, where they can at the very least live a good quality of life for hopefully at least 5 years, and if Allah wills, longer than that. But if we catch them later, so currently in these 37 years, we've not made a lot of headway regarding 5 year survival loss. So thank you very much for bearing me. If there are any questions, I would love to take that. I've answered one, I think. I'll see if there are any other questions. So I think Dr. Shahzadi, I think after question, hopefully I've answered. Uh, One question by Dr. Suhaib Ahmed. Do you think dental public health is effectively playing its own early detection? If not, what strategies should be implemented as current studies show significantly decrease in incidence? Like I said, I'm not a dental public health guy. I don't have a lot of friends in dental public health, but of my seniors who are in public health, I know most of their PhDs and MPhil research is around squamous cell carcinoma and tumor markers and whatnot. But I personally feel this question should be best answered by a public health specialist instead of me. But I will say that when I was a second year student in way back in 2008, if I'm not wrong, and we were, I think, taught community dentistry for the second time in our history at our institute, so the Begum Dental College. So at that time, there was no focus on oral cancer, if I'm remembering my course correctly. So we were focusing more on DMFTs and KDs and periodontal health and whatnot. So if I remember correctly, we were not taught anything about oral cancer detection back then. So I hope that in these 20 years, something would have changed in this regard. But I hope public health experts can talk a lot more about this. So, all right. I hope that answer question is answered. Another question: what long-term oral complications should we monitor clinically? I would suggest always look for development of an ulcer if an ulcer is not healing, and always check that is can you feel any induration. It feels like this structure is attached to the underlying submucosa or to the skin or to the buccinator muscle or something. So these are two things you should monitor very commonly, so you can get an idea that is this thing progressing towards malignancy or not. So that's why I was focusing a lot more on palpation instead of the other adjuncts. How do we clinically assess patient's fitness for surgery? Well, a lot of factors, but the most important factor is actually from the anesthesia point of view. So again, since a lot of these cases report after 50s, 60s. So the problem then becomes that they develop a lot, usually comorbids उससे develop हो गए होते हैं. So there could be cardiac issues at play, there could be diabetes, there could be kidney problems. So anesthesia is a lot bigger concern for fitness for such cases. In addition to this, if you go through the TNM staging of such cases, so you will come across something that there when squamous cell carcinoma, any tumor has progressed beyond a certain boundary or involved certain structures, then usually we consider such patients as having unresectable tumors. So that is a separate topic, and I think probably Asalan might cover that a lot in next dissection, etc. So probably I think I'll leave that for him. He may cover it better. So, but major issues do come from the fact that can we get clear margins and whether we can whether the patient can survive the surgery. Because remember, you're not only creating a defect, you have to reconstruct that defect as well. So such cases typically last, I would say, maybe 6 hours, 6 hours, 9 hours more, depending on how much tissue you've taken out and how much reconstruction you're doing. All right. Uh, I'm getting a lot of thank yous. Oh, thank you very much. Still, if you have any questions, I would love to take them if there is time. I think I've taken a lot of time from the next speaker. But anyhow, if there are any questions, please let me know. I'll share this presentation, inshallah, with Dr. Saman and the rest of the team of site. So if you liked anything in it, so you can browse more in detail. And if there are any questions, I'm sure they'll forward them to me. So I would love to answer them. So, but if that's all, so then I'll take my leave.
Thank you very much, sir, for your time and your contribution and for the insightful session. We are truly delighted to have you. So thank you for answering all the questions yourself. Thank you once again. And sir, there are literally so many appreciation and thank you for you. Your session was truly inspiring and insightful. We look forward to having you more into our sessions. And till then, sir, take care. Thank you.
Thank you very much for having me, and thank you for Pride for having me again. This is my second collaboration with them, and I hope it went as well as the first one was. So
Yes,
looking
sir,
forward to
definitely.
collaborating